Seizures in children. These usually really tend to freak people out. In general, we can classify them into four categories: generalized, absence, juvenile, myoclonic, and partial seizures. And from there, we can kind of break them down further. Seizures are uncontrolled electrical discharges of neurons from the brain. So it's kind of like an electrical storm that is just crapping out neurons and neurotransmitters all over the brain, basically. They are associated with immaturity of the CNS, fever, infection, neoplasms, cerebral anoxia, and metabolic disorders. Generalized seizures in children are rare before 6 months of age, and if they occur, it's usually due to a strong familial tendency. They are usually abrupt in their onset. Children may have 1 to 2 minutes of loss of consciousness, and they will have some post-seizure confusion. They may or may not have an aura. The body becomes rigid in the tonic phase, and the muscles contract with seizure-like movements. That's the clonic phase, hence tonic-clonic. Pupils usually dilate, eyes roll up, and they may have some drooling or foaming at the mouth. They may have loss of bowel and bladder control. It may be caused from trauma, perinatal trauma, tumors, lesions, metabolic, and neuromuscular disorders. It can also be caused from genetics, and sometimes they're just idiopathic and we have no idea why kids seize. Truly. Febrile seizures occur in 2 to 5% of children who have a fever greater than 102.2. So that's not super high to make you seize. And not every kid is going to have a febrile seizure either. Children will usually outgrow febrile seizures by 5 years of age. Absent seizures usually occur in kids ages 3 to 12. It's common to get remission of these in adolescence. These are more common in females, may develop into generalized seizures later. They may be triggered by flashing lights. They may have a brief loss of consciousness, like 5 to 10 seconds, but it rarely exceeds 30 seconds. There's usually no post-seizure confusion, lethargy, or confusion. Actually, the child may have some amnesia regarding the seizure. They may have 50 to 100 of these per day, and it often interferes with their schoolwork. These cannot be stopped with verbal touch or touch stimulation. The child may have a slight loss of muscle tone and may drop things. Usually these have a genetic predisposition. Juvenile myoclonic, these usually have a genetic predisposition. These are more prevalent in adolescents with a peak age of 12 to 15 years. There is no loss of consciousness, no post-ictal period. These usually occur while falling asleep or awakening. There may be quick involuntary muscle jerks of the neck, shoulders, or the arms. Injury is possible if the child is thrown onto the ground or like rolls out of bed. Partial complex, these are caused from cysts, tumors, perinatal trauma, and brain scarring from febrile seizures, vascular anomalies of the brain, and brain trauma. Age of onset is usually 3 years to adolescence, so pretty much most of childhood. Loss of consciousness during seizure can occur. It may last up to 5 minutes. The child will probably have post-seizure amnesia or confusion. They may also have abnormal tone, numbness, or tingling. These can progress into a generalized seizure. These are frequently accompanied by an aura, a feeling of like deja vu, anxiety, or fear. These children may have automatisms, which is lip smacking, lip chewing, or sucking during the seizure. And then we have partial simplex. I don't think there's anything simple about a seizure at all. These occur due to focal damage such as CP, tumors, lesions, blood vessel malformations, and brain abscesses. These can occur at any age. There is no loss of consciousness, and these last no more than 30 seconds. There's no post-seizure confusion, no aura. They may include paresthesia or other sensory sensations, and these also can progress to a generalized seizure. Here are two more types of seizures that we see in children. Infantile spasms. These begin between 4 to 18 months of age. These are more common in males. They can occur with a complex partial seizure. This is an extremely very severe form of epilepsy. These children can have these 5 to 150 times a day. Seizure activity increases over time. Developmental delay and cognitive disability do occur. Infantile spasms are a devastating thing to occur because every time the child has a seizure, it starts to unwind all of the development and all of the growing that the child has done from a cognitive and from a developmental standpoint. Lennox-Gastaut syndrome, these are called akinetic or atonic seizures. These can be idiopathic in origin or from the gray matter degenerative diseases. These are seen early in childhood, ages 3 to 5, again, mostly in males. Combination of tonic, absence, and myoclonic seizures. Children can fall to the ground with a sudden loss of postural muscle tone. They have an inability to break their fall. They can get very hurt from these. Usually they are limp for a period of time. These are associated with cognitive impairment, delayed psychomotor development, and severe behavioral problems. Remember, seizure manifestations in babies may only be manifested by repeated blinking, lip smacking, tongue thrusting, pedaling movements like when they bicycle their legs, or sustained posturing. Seizures in babies are pretty subtle. If you think a baby's having a seizure, because babies will, sometimes babies get jittery, easiest thing to do is put your hands on them. If they're jittering and moving their arms and their legs, and if you put your hands on them, if it's just jitters, that will stop it. But if it's a seizure, it's going to continue. Epilepsy is a chronic condition characterized by recurrent and unprovoked seizures secondary to a brain abnormality. It only takes 2 seizures to get this diagnosis. Why do we care? Because on my slide I'm reading through it as I'm recording this for status epilepticus. We care because each seizure episode can compromise the airway, which leads to cerebral hypoxia, and then neurons start to die. Remember, I'm going to beat it like a dead horse to you guys. The brain is fussy about its oxygen. Metabolic rate, the basal metabolic rate also increases during seizures, which only increases the demand for oxygen and glucose. Seizures can be caused by a variety of pathological processes in the brain. Optimal treatment and prognosis requires an accurate diagnosis and a determination of the cause. Don't you love the clever title of this slide? I liked it because it's inevitable. You are going to encounter a child or an adult at some point in your nursing career who's having a seizure. Seizures generally provoke a lot of fear and anxiety among people, including nurses. So I thought it'd be worthwhile to go through and talk through what do we do in the event of a pediatric seizure. Good news is seizures usually are self-limiting. Step 1 for NCLEX world, protect the child from injury. That includes making sure the side rails are padded. That includes carefully lowering somebody to the floor, doing whatever you have to do to protect them to make sure they don't harm themselves while they're having the seizure. You would turn them on their side, maintain their airway and suction secretions. If you're at home, obviously you're not going to have suction equipment available to do that. But you do want to monitor the airway and try and maintain it because the airway can become compromised with muscle rigidity. In the hospital setting, you'll keep suction equipment handy. You're going to administer O2 by mask because does it do you any good to slap a nasal cannula on somebody? No. Mask O2 really doesn't help a whole lot either because if somebody isn't breathing, blowing, everything, it doesn't matter how much oxygen you blow in front of their nose. If they're not breathing, they're not going to take it in. However, we do give oxygen because when they do start breathing again, we want them to breathe in oxygenated air to help them rebound and recover from the seizure faster. We will monitor vital signs. Always keep an eye on that pulse ox. You're going to keep an eye on their respirations and their heart rate too. Do not place anything in the child's mouth. No bite sticks, but I think you guys all know that by now. Perform a neuro assessment every 5 to 10 minutes. And you guys go, what is a neuro assessment? We went over it on part 1, so reflect. And then you want to keep track of what was the child doing before the seizure. What were the seizure manifestations? What was the length of the seizure? So document, document, document. All right, more interventions. If you are in the hospital, or if you think it's appropriate, then you want to either get an IV line. Hopefully, if they're already in the hospital, they already have an IV line placed. And then you can access it to give medications such as IV phenobarb, Ativan, diazepam, and Versed. Doses may have to be repeated, and more than one med may be needed to stop the seizure as well. Check a blood sugar. Why? Because you check a blood sugar to check for hypoglycemia, because that may be the cause of the seizure, or it may result from the seizure since seizing increases the metabolic rate, which means your body is going to use up glucose and oxygen faster. So if somebody has been seizing, you want to check a sugar, or if they just start a seizure, check a sugar too, because that can be a cause of the seizure, hypoglycemia. If you're in the hospital, of course, you would drop an NG tube, possibly, to prevent aspiration from vomiting. And I say possibly because that's not always a hard and fast rule. Be aware that the cumulative doses of benzodiazepines and anticonvulsants may build up and result in apnea. So, monitor the child very closely. One time we had a baby in the NICU who seized, and we pushed phenobarb, we pushed Ativan, we pushed another dose of Ativan. We pushed so many drugs at one time that this poor baby, we finally stopped the seizure, and we stopped the baby from breathing too, because she was absolutely just snowed after all of this. So she ended up having to go back on the vent for a while until those meds wore off. Patient may need to have an EEG afterwards to ensure that the seizure activity has stopped. If the child takes anticonvulsants regularly, then they need to have a random drug level drawn to make sure that they are still in the therapeutic range. Remember, these are kids. They are constantly growing. So when kids do have a breakthrough seizure, often that's the first clue that they need to up their maintenance dose of medication. And then you'll, of course, want to implement seizure precautions, box 45-9 on page 1452 in your textbook. Again, I'm going to reference box 45-8 on page 1451 in your textbook. But these are just some other good questions to ask about seizures. And the next 3 slides just go over some of the different seizure medications that can be used and some of the important nursing interventions that go along with them. If I were you, I would look at them because there are going to be questions about them on boards and probably your exam as well. As far as long-term management of seizures, most seizures are going to be treated with monotherapy medication, meaning one medication, and that is successful in about 60% of children. Single drug therapy is preferred so that the side effects are minimized. Side effects include sleepiness, decreased attention span, difficulty with speech, ataxia, and diplopia. The med is increased until it is in the therapeutic range or until the seizures stop or until the drug reaches its max dose. Then a second drug is added if need be. Surgery can be done, depends on the type of seizures that the child is having, but they will actually go through and they will remove the part of the brain that is damaged if they can. Obviously, the earlier this is done in a child's life, the better, because then the child will form new pathways and learn to compensate for the missing brain or brain part that they have. The ketogenic diet is another long-term management treatment. Ketogenic is a high-fat, low-carb diet. Family has to have a lot of education and they have to have a very strong commitment to do this. They meet with a dietitian for help and they basically have to keep the child in ketoacidosis. This allows the brain to heal. The diet goes on for 1 or more years and then it is slowly phased out. Carbs are slowly phased back in. I know a family that did this when their child had seizures. He started with infantile spasms, and the family tried a few different meds, and one of them ended up causing some visual impairment in their child. And so they went to the ketogenic diet, and they did it for about a year. And Yeah, the child stays seizure free for like 3 years afterwards. Long-term effects of having seizures: depression, because that's just depressing for kids to have to deal with this. Anxiety, ADHD, conduct problems, and aggression. There is a great seizure care plan on page 1452 in your textbook if you're ever in clinical, um, and your child is in clinical, or the child you're taking care of in clinical is there because of seizures. Great, beautiful care plan right there in your book. Easy to go. Hydrocephalus. So your CSF is produced by the choroid plexus within the lateral third and fourth ventricles, and it's produced at a rate of 500 mLs a day. That's a lot. So hydrocephalus obviously results when there is an imbalance between the production and the absorption of the CSF. Congenital clinical signs are listed for you on your slide, but they generally arise from some sort of congenital structural defect or syndromes, such as Dandy Walker, the Arnold-Chiari-2 malformation, aqueductal stenosis, or some sort of acquired injury from infancy or IVH. So, clinical signs for acquired hydrocephalus would be symptoms in an older child after the closure of their sutures from something post-infectious, tumor, hemorrhage from trauma, something like that. So hydrocephalus is diagnosed, by CT, MRI. They'll do a head ultrasound in babies because the fontanelles are still open so they can see. They can do surgery to remove the obstruction, and they'll do surgery to place the shunt. The shunt consists of 4 parts: the ventricular catheter, the pumping chamber / reservoir, and a one-way pressure valve, and then a distal catheter. So some of the complications of shunts fall under the mechanical category. You can get blocked catheters, kink tubes, valve breakdown, all those things. But shunt infection. The period of greatest risk for a shunt infection is 1 to 2 months after shunt placement. Infections are a big, big, big deal. They can lead to septicemia, they can lead to bacterial endocarditis, wound infections, shunt nephritis, meningitis. Treatment is going to be massive dose antibiotics, and they'll have to pull the shunt out. Usually these kids get admitted to the PICU, they get their shunt pulled out, they go through 2+ weeks of hard IV antibiotics, and then when they are cleared, all their cultures come back negative, then they go back to the OR and have another shunt placed. All right, nursing care for taking care of a child with hydrocephalus. Measure the head circumference daily. You need to communicate with the other nurses and make sure you guys are all measuring in the same spot. Usually we measure right around the eyebrows. That is usually the place where it's measured. Make sure you support the head. You may have to get like some foam pillows, like the little foam egg crate pillows from OR, that are help to relieve pressure, because you want to make sure that you don't have skin breakdown on the back or the sides of the baby's head. The baby may need small or frequent feeds to decrease vomiting. Let's see, you can probably read through the rest of this stuff on your slide. This is a biggie though. This is the NCLEX stuff. Teach parents the signs and symptoms of increased ICP. Because if the shunt fails, what is the child going to experience? Increased ICP. So you want to teach them signs and symptoms of shunt failure, which is going to be basically the increased ICP. You want to teach them about any kind of unusual irritability, bulging fontanelles if it's a baby, separation of sutures if it's a baby, increasing head circumference, vomiting, diminished appetite, sleep pattern disturbance, or fever. In older children, you want to teach, again, signs of increased ICP: headache, nausea, vomiting, decreased level LOC. Teach them to watch for signs and symptoms of a shunt infection. Watch for redness, swelling, or pus at the incision or along the shunt track. Make sure you tell them eventually this child will probably need a shunt revision. Most shunts end up getting infected at one point or another. I took care of a baby in the NICU one time, and they had a shunt placed. for comfort care only, because the baby was supposed to be terminal, but he's now 5 years old, so I don't think he's that terminal. Um, anyway, they had the shunt placed. They went home from the hospital, and they called me back in the NICU when I was working, and they said, something's not right. We're doing this. And immediately she said shunt, and immediately I thought it's infected. And so we went over the signs and symptoms, and I said, you need to take him to the ER. I hate to tell you that, but you're going to have to do it. So when I got off work, they were in the ER. I went downstairs and met them in the ER, and I looked at this baby's head, and it was oh so subtle, oh so very subtle, like a tiny, tiny, like pinpoint piece of green, neon green colored crust right on the shunt site was on this baby's skin. And I looked at it and I pointed to it and I said, boom, there's your infection right there. And so then the neurosurgeon came in and goes, oh, you're here. I'm like, yeah, I'm here. I travel to different departments sometimes. And he did a tap and just tapped directly into the shunt and started pulling out this awful purulent fluid, which showed us that yes, the baby had meningitis. Baby did have a shunt infection. So baby was admitted to PICU and stayed there for, I don't know, 2 or 3 weeks while they pulled the shunt out, cleared the infection, and put a new shunt in. So important to really go over discharge teaching, because that's going to save your patient's life. It really will. Oh, you've reached the end. This is all the cerebral dysfunction, or cerebral dysfunction that we're going to cover in this chapter. Congrats!